Hey guys, this is Austin Nakas here at the Moran Eye Center in Salt Lake City, Utah, and today I'm going to be talking about dealing with anterior capsule tears and cataract surgery and a few pearls on how to deal with them during your nucleus removal and your cortical removal as well. So for the most part, when you have anterior capsule tears, a lot of times they end up toward the nose, if you're sitting temporally, that is, or at least away from you. And the reason for that is pretty simple. For the most part, this is the area where you're doing most of your work. So essentially, if you have your phaco tip here and you're reaching over and you're doing work removing nucleus here, your sharp tip of your phaco tip can pretty much nick that anterior capsule there. Or your chopper here can go ahead and nick that anterior capsule there as well when you're reaching for a nucleus and trying to crack it or break it. And so a lot of times it'll end up away from you. Now that being said, it can happen in a lot of other places as well. For instance, when it happens with the capsular rhexis, it can pretty much happen anywhere in these areas. And if you're, say, cross chopping with the chopper, you can reach over and nick it over here and have an anterior capsule over there. But for the most part, a lot of it will be kind of away from you. And so how do we deal with this anterior capsule tear? Well, for the most part, one of the main principles is that you're trying to not extend this and make this bigger. And so what you're trying to do is avoid basically any sort of stress or forces that are causing that tear to extend, or basically moving any of those forces away from that anterior capsule. And so you want to avoid those kinds of movements. And so when it comes to, say, nucleus removal, a lot of times what you're doing is rotating the nucleus, right? You may rotate it clockwise or counterclockwise. But in this scenario, you kind of don't want to rotate the nucleus very much at all, because essentially what you're doing is putting forces away from that anterior capsule tear, and that may cause that tear to extend further back and out. And what you don't want is you don't want it to extend around the capsule and basically become a posterior capsule tear. And most of us know what happens in that situation. It's a much bigger deal. And so if it is restricted only to the anterior capsule, you can still kind of safely deal with it and sometimes put a lens in the bag. And so you don't want that to extend any further. So you want to avoid movements that rotate the nucleus, that put forces on that anterior capsule. And so how do we do that? Well, there's a couple of different ways to do that. So many of us are familiar with the general divide and conquer, where basically you make a groove and a crack right here, and then you rotate it and essentially make a groove and a crack in the same area, and it's still sort of separating apart left and right. Well, the problem with that, as you can see, is the forces are still going this way. And so you're still kind of putting some stress right there if that anterior capsule tear is over there. So you kind of want to avoid that if you can possible. Now, that being said, it's still possible to do, and you can still do so safely if you're very careful with it and you know where your crack is. But for the most part, if you can avoid it, that would be great. And so there are other ways to kind of remove the nucleus without rotating it quite as much and without making that groove right down that center. And so one technique is actually called the V technique, where essentially instead of making the groove down the center, you make the groove this way and you make the groove this way, and you use your phaco tip, and you can basically make your groove here and here. And then you can separate it into three pieces: 1, 2, 3. And instead of having 4 pieces to come out, you have 3 pieces, but you're not putting quite as much stress right across on this anterior capsule tear here. The stress is sort of directed this way, and actually when you're cracking, some of that is kind of moving back toward the anterior capsule tear. So that's a little bit better. And then you can avoid some of the rotations that you do when you have 4 pieces. You basically just take out this piece right here, and you can either take out this piece and turn your phaco tip to grab this piece and this piece, or you can rotate it this way and this way in front of you so that the rotation is actually toward the anterior capsule tear, not away from it. And so then you can remove all 3 pieces. So that's one technique on how to kind of avoid those movements that will extend that anterior capsule tear even further. And I actually have a video of that posted on YouTube as well if you want to look it up, or you can just research or look up Google V technique for anterior capsule tears. So let's talk a little bit about cortical removal. So say you are able to remove the nucleus safely and you still have the anterior capsule tear, but it's just restricted to the anterior capsule, and you have all this cortical remnants left, okay? Well, essentially with that cortex, a lot of people will start pulling that cortex kind of toward the center of the eye to help remove it there. And that's kind of called pulling it radially. And there's a couple of issues with this, especially with an anterior capsule tear, is basically, think about it, when you're pulling when you're pulling cortical remnants away from that anterior capsule there, you're putting stress there, and that can basically make it extend out. So you kind of want to avoid putting stress directly in that area. Number two is, this has been shown before, but basically by pulling radially or toward the center, that actually pulls the zonules more than if you actually remove it circumferentially like this. And so we call that the hurricane technique, or it's been coined that term, because essentially what you're doing is a circumferential removal, and that reduces the stress directly on the zonules, because the forces, instead of being directed directly away from the zonules, it actually kind of directs it sort of tangential to it. And so you can use this technique with the anterior capsule tear as well, and it's actually a really smart thing to do. The only thing though is this: you have to be careful about which way you are pulling your cortical away from this capsule tear. So again, remember, we're trying to limit movements that come away from the tear to limit it from rotating around to the back. So instead of pulling, using your cortical removal, instead of doing your cortical removal to pull away from that area, you want to basically pull it toward that area instead. So if you have cortex here, you have cortex all around, pull it toward that area so that the forces are directed inward, almost like it's closing up that gap instead of pulling it away. And you want to be very careful during that segment as well, because essentially that is very close and up against and adherent to the anterior capsule, the cortex is. And so those pulling movements can really put a lot of stress and pressure right here. And if you can do those things, you may be able to avoid extending this anterior capsule tear larger and around, and avoid making it a posterior capsule tear as well. There are also ways to determine whether or not this is only restricted to the anterior capsule or posterior capsule, because sometimes you can't see. And there's actually a video published called the flap motility sign that you can look up as well, that basically shows that if you can see this flap moving during your phaco or cortical removal, then most likely it's restricted to the anterior capsule only and has not moved posterior. But if this stops moving, the flaps here, then essentially that has probably gone posterior and you're dealing with a posterior capsule tear. So hopefully that has helped you out today in giving you some pearls on how to deal with anterior capsule anterior capsule tears. This is Austin Nakasuka from the Moran Eye Center. Thanks for listening in.